Welcome, welcome, welcome in everyone. Welcome to Care Concierge with Carepatrol, where education is the heart of everything that we do. We appreciate you sharing this beautiful fall Monday lunch hour with us. And we appreciate all of you for everything that you do. And we're very pleased today to begin our October series, which focuses specifically on clinical topics delivered by clinicians. And so we have a full slate of folks for October, and we're actually already lining up some clinicians to speak for Carepatrol and for Care Concierge in November. And I will ask again, those of you who would like to present yourselves, who are today attendees, please let me know. I'd love to give you an audience and a voice and an opportunity to share your knowledge with others. As we're doing things a little differently today, I will go through our housekeeping just a minute early, as I usually wait just a moment and let folks log in and get loaded up, but folks are still joining in, and I'll continue. Those of you who just joined us, welcome to Care Concierge with Carepatrol, where education is the heart of everything that we do. You know, we educate our clients, first and foremost, those who are aging adults or families or loved ones of aging adults who are no longer safe and independent at home. We counsel them about what options may exist, what options do exist, and which options are within their budget, and which options would be the safest outcome for their loved one. This might be assisted living placement, in which case we would be paid by the assisted living and never by the aging adult or their loved ones. And so education for others is what we focus on in our business practice, and it made sense for us to try and also help educate clinicians in our state and beyond. And again, today we're starting with our October series focused on clinical topics delivered by clinicians. As those of you who've participated with us before know, we are credentialed and accredited by the Alabama Board of Social Work Examiners and the Alabama Board of Nursing Practitioners to offer these contact hours. We do so by means of an evaluation. In this way, we show that the presentations are live presentations, equivalent to face-to-face presentations, because using our evaluation, we password protect it and do not give the password out until later this afternoon. This way we can verify to these boards that you were here in attendance, that you gained the education, that you were live and fully participated and heard the password. Please do listen for it. I will probably end up interjecting at some point around 12:45 or 12:50 and sharing the password with you all. You have the ability to unmic yourselves. You can ask questions as needed, and I hope you'll get in a very good discussion today. I'm so pleased to have presenting for us today my former colleague and I feel dear friend, Dr. Phyllis Grauer. She is, and those of you who work in hospice may know her name, she is a celebrated educator and pharmacist in the hospice realm. She has participated in the creation of countless hospice formularies and other formularies. She is expert at what she does, and she is so kind to share her information with us as a favor to me, and I do appreciate it. She normally, I'm sure, would command a high fee, but we're so pleased today to have Phyllis join us, Dr. Grauer. And I've put in here, for those of you who can use the chat room and know how to make use of it, I've put her biography as well as some objectives at the end of that. If you'll start at the top and scroll down, you'll get a better sense of Dr. Grauer's experience and expertise. And in addition, you will be able then to better evaluate our services and the education that you receive today. So we're so pleased to have all of you here. It's currently about 12:06. I will turn the floor over to Dr. Grauer. Let me do one thing first. Let me read before I do, excuse me, Dr. Grauer, before I do, there are those who are regular attendees who attend by phone and cannot see a screen. And so I'm going to read for those folks who are hopefully going to be able to make note of it, our evaluation link. And it is https://www.surveymonkey.com/lowercase r/ and these are all uppercase letters, Z as in zoo, B as in boy, Q, F as in Frank, D as in David, B as in boy, 2. I'll read it one more time and then cede the floor to Dr. Grauer. Our evaluation link for today, and remember that the evaluation is password protected, is https://www.surveymonkey.com/lowercase r/all uppercase letters, Z as in zoo, B as in boy, Q, F as in Frank, D as in doll, B as in boy, 2. And Dr. Grauer, I'm happy to welcome you. I'm so pleased that you're here for us, and I'd like to turn the floor to you.
Thank you, Sean, and thank you everyone for joining us today. It's really a pleasure to be here, and senior care is a very important part of my life. I was able to utilize a service similar to Carepatrol years ago when my parents were elderly and needed some support, and so I can tell you in just probably a few short years, my children will be using it for myself. So anyway, let's go ahead and get started. And I always have trouble with this first slide. Let me advance. There we go. I think we'll be okay from now on. Whoops. So there we go. The title that Sean put was Geropharmacy. I prefer to call it medication considerations in older adults. And in this situation, everyone needs a pharmacist friend, and we're going to talk about that and why it's important. So the objectives that Sean has put in the chat are this: at the end of the presentation, the participants, I'll get my words out, should be able to describe the challenges that older adults face with safe and effective management of medication, list the common misadventures, and then discuss, excuse me, how a specially trained older adult pharmacist might be able to help in these situations. I am going to move this so I can see better. There we go. So how can we help? Well, when we think about it, our patients are, or you as an individual, are on many different types of medications, prescriptions, over-the-counter medicines, herbals, and supplements. And so as a clinical pharmacist, I want to join those individuals on the road to make sure that they're using them safely and effectively. So I'm going to invite you to unmute and tell me what you think about what comes to mind when you think of a pharmacist. If I said, "Hi, I'm Phyllis, I'm a pharmacist," what would you think? Anyone?
they may not know yet they can unmute, but some of them will unmute Dr. Grauer, and then some of them like to use the chat room. If they chat, I'll add it to you or let you know.
Okay.
Oh, here they come. Good morning, everyone. Welcome, Dr. Grauer, my medicine doctor, hometown.
Medicine doctor, hometown.
Two different responses.
Oh, medicine doctor.
Med education help, says Tonda Smith.
Well, I'll tell you, when I poll people, and I even polled one of my closest friends growing up, and they think about the person at the chain store, drug store behind the counter that they really never talk to. So honestly, when I introduce myself, I don't say, hi, I'm Phyllis, I'm a pharmacist. What I say is, I am specialized in pain management, end-of-life care, and geriatric medication use. I'm trained as a pharmacist. That's a lot different than if someone just thinks about me as that person behind the elevated counter that they never get to talk to. So that's really common. So basically, we are medication experts. Until 2000, which is prior to 2000, I graduated with a BS in pharmacy. That was a typical degree. After 2000, it became mandatory that every pharmacist, in order to be licensed, must be a doctor of pharmacy, which means that they have anywhere from a 6 to 8 year training. And then there are many that go on to get advanced training. So we're very similar to medical doctors in our training these days. Unfortunately, we don't have the same ability to bill like they do, but we do have extensive training. So we're basically the most educated healthcare professional as with respect to medication, even more than doctors. So we know drugs. So the typical, and are you hearing a echo, Sean?
No, maybe it's me. Let me.
I'm hearing a bit of an echo. So anyway, as a pharmacist coming out of PharmD school, we had a broad understanding of medications related to most disease states. And it's kind of like a medical doctor coming out of their medical training. They have a broad understanding of disease states and some training in medication. So we're not just counting, licking, sticking, pouring behind the counter. The dispensing is incredibly important. They need to do it right. Obviously, right now, pharmacists are really getting paid tied to the product they dispense. But in certain circumstances, they can bill insurances, for example, immunizations, which are common in many of the pharmacies. Clinical consultation, which is what I've done my entire career, mostly in hospice, now in chronic disease management, pain management. Specialized pharmacy practices usually require advanced training, a 1 or 2 year postgraduate training, and sometimes a fellowship. You'll often see a pharmacist working in physicians' offices, having appointments, maybe working with diabetes, with asthma, things like that. I have spent the bulk of my career, in addition to my clinical consultation, as an educator in colleges of pharmacy. Hospital pharmacists can either be dispensing or they can be on the floors rounding with physicians. And again, those are the specialized pharmacists with additional training. And then there's drug manufacturing and sales where pharmacists are involved. So it's not just that elusive person behind the counter that the technician says, do you have any questions for the pharmacist? So let's look at really what an adult care pharmacist does. So many of us have board certification, just like physicians. I happen to be board certified in geriatric pharmacy. So you will see someone like me have like BCGP, which means board certified geriatric pharmacist. And that's rigorous education to pass tests, lots of continuing education to maintain that license. So I focus on older adults. In hospice, the majority of our patients were older adults. And as my children would say, yeah, you're board certified in geriatric pharmacy because you are a geriatric. And I am indeed a geriatric. I am over the age of 65. So what we do is we manage all the medications as it relates to older adults, and we help to identify, resolve, and prevent problems of medication that are not only the prescribed medications, but those that people buy over the counter, those supplements and orals. But predominantly what we do, and really what every pharmacist should do, even when you're getting your medication, is to educate you. And certainly with respect to older adults, there are a lot of issues or considerations that are specific to that population. So what does an older adult pharmacist do? If I'm working with a patient, I provide one pair of eyes. So we work together with the individual, their doctor, nurses, and pharmacies. We look at all their medications, as I mentioned before, and we provide education to support the proper medication use and effectiveness. Because if you're not properly using them, they're not effective. And sometimes even if you're properly using them, they may not be effective for the intended purpose. So we monitor that. And then the other thing that I have found that has been very encouraging to those loved ones that live far away or even close by, to an individual who may be in, let's say, assisted living or independent living or even in their homes, is to keep them up to date and make sure that they have a comfort level that someone is watching over the medications that their loved one is receiving. Now, there's some very important facts that you should know about managing medications in older adults. First of all, seniors use more medications. As of the 2020 census, there's about 17% of our population that are over the age of 65. And interestingly enough, they use about 48% of all prescribed medicines. So you can see that there's a lot of medications in this particular age group. Multiple medications increase the risk of drug interactions and side effects. Now, as we age, our liver and our kidney function decline, so medications need to be adjusted or even avoided in that patient population. And because a lot of times the medications stay longer in the body, there's protracted side effects or adverse events that can occur, so doses need to be adjusted for that reason as well. And as we age, we have changes in our body. We have weight loss, some of us have weight gain, we have decreased body fluid, but we have increased fatty tissue. Now, medications that kind of hang out in the water are going to have less volume. They may become more concentrated. Those that hang out in the fat may stay in the body longer, but become less, require a higher dose in some circumstances. So we have to look at those body changes as time goes on and adjust medications appropriately. Increased sensitivity to medications, particularly things like dry mouth, urinary retention, sedation, things like that. Decreased blood pressure as someone stands, we need to be aware of that. And because we have memory, hearing, vision decline, and even from the standpoint of our physical strength and mobility, and certainly memory lapses, we may not be taking our medication appropriately. I know for me, I always ask for the easy open caps because I have arthritis. I cannot always grasp those lids and things like that. And then we'll talk more about how we can help with impaired memory as we go on. So older adults tend to receive medications from different healthcare professionals. We go to our primary care physician, we go to our rheumatologist, our cardiac physician, our pulmonary physician. There's a lot of physicians we go to. And then sometimes we'll have additional physicians such as orthopedics if we happen to have a fracture. They prescribe medication, not necessarily knowing what another prescriber has our patients on that might interact. Now, obviously, as we age, one of the reasons why we're living longer is because chronic diseases such as diabetes, hypertension, cardiac disease, arthritis, they're being managed better with medications. So we do have an increase in the number of chronic illnesses that we see in older adults. And finally, older adults have a tendency to not be able to follow medication instructions, and we call that non-adherence. Now, what does non-adherence mean? Well, 1 in 4 older adults skip doses or they don't fill prescriptions because of cost. They may fail to take the prescribed medications. 76% of patients who fail to take the medications will experience significant decline in their health. That's a pretty high number. And then according to some research, 60% of older adults take their prescribed medications inappropriately. And here's an astounding figure: about 140,000 people die each year as a result of not taking their medications properly. So obviously we need to work on reducing that number. So what are the benefits of appropriately taking medication? Well, when we appropriately take it as prescribed, it's administered appropriately, it's monitored, it's really more cost effective in maintaining a patient's health than not doing so. Otherwise, people are going to end up in the hospital. They're going to end up with falls where they may fracture, all sorts of adverse effects from not properly taking their medication as prescribed and administering it and monitoring whether or not it's even appropriate. So older adults can live longer by carefully following their doctors and their pharmacist instructions regarding medications. So managing these medicines, it's not an easy task. An older adult pharmacist will help reinforce and further explain why their doctor has the individual taking the medication. Let me just give you some examples. So a physician prescribes, let's say, a drug like hypertension medicine. The patient feels a little dizzy the first few days. They just don't feel too good. So they quit taking it. Instead of knowing that that medication may make you feel kind of crummy for the first few days, but you got to continue to take it so your body will get used to taking that medication. Who's telling them that? So we need to be able to explain that. Patients taking an antidepressant, they start taking it, they really don't feel the effects, but they're going to continue to take it. And then, they're just not feeling it, so they just stop abruptly. Well, when you take that medication for a little while and you stop it abruptly, you have what's called an abstinence syndrome, and you get all sorts of adverse effects. And instead of waiting the 3 to 6 weeks to see if it's effective, or even after 3 to 6 weeks, if it's not effective, talking to the physician about saying, well, maybe we need to adjust the dose. You need to understand why the doctor has prescribed it and how to take it appropriately and what happens if you don't take it appropriately. And then giving tips on taking it properly might include, well, you take this with food, you don't take this with food. Taking it properly as far as, well, this medication says 3 times a day, so do I take it with all my meals, or do I take it every 8 hours so it will have an even blood level? It depends on the medication, whether or not that's important. And if the medication is started at a too high of a dose and it has side effects, do you know to call the doctor and talk about that and maybe have the dosage stop, or adjusted, or do you stop it on your own? So being able to understand that is important as well. So what are the common side effects? Now, we all get those pages and pages of drug information leaflets. And my dad read every single line and started to experience every single side effect. Well, under the FDA's rules, they have to report any side effect that occurs over a certain percentage, 10%. And 10% means 90% of the people don't get it. So we have to be able to point out the appropriate side effects and then look at the other medications that they're on to make sure that there's no drug interaction with any of the other medications they're taking, even over the counter herbals and supplements. So understanding those leaflets are very important, and being able to not get scared. Another example that you can use related to the leaflets, let's say a patient has been prescribed a drug like duloxetine, which is, the brand name is Cymbalta, and it says it's an antidepressant. But the physician is not prescribing that for depression, they're prescribing that for pain. So if you read, hey, they gave me an antidepressant, they must think I'm crazy, so they don't take it. So you've got to understand why you're taking it and evaluate the information that you're given to the point that it doesn't scare you, or it doesn't psychologically cause you to have side effects that normally wouldn't be there. And then finally, I think, well, not finally, but one of the things that I see a lot in our older adults is they're taking medication that is no longer necessary. And that includes prescribed over-the-counter and herbal medicines. Now, let me give you an example of that. You go into the hospital, and in the hospital, you're there for somewhat of an extended stay. And the prescriber puts you on a drug called omeprazole, which is the brand name for Prilosec. And that's very common, particularly in older adults, to prevent gastritis that is caused by the stress of being in a hospital. So you get your discharge summary from the hospital physicians. My daughter happens to be a hospital physician, and they're going to write the prescriptions directly related to what was prescribed in the hospital. So you go home on that omeprazole, and now you're taking it for months, years, and it's really no longer necessary because it was prescribed for a particular purpose. And unless that individual who's sending that patient home understands that that's why it was prescribed, which they may or may not know why a certain doctor prescribed it, if it's not that particular person, then you can have this unnecessary medication. And that unnecessary medication may cause problems down the road. It may lead to some infection due to decreased acid. And there's a number of examples of that. Another good example might be that you were prescribed a different blood pressure medication than the one that you were taking at home because it's not on their formulary. So the doctor then gives a prescription for the one you're on in the hospital. Nobody tells you that you either go back to the one you were on previously, or you quit taking that, and then you're taking double the medications when one of those should be discontinued. So there's just a whole plethora of reasons why that can happen. And then another important thing is, because we have people going in and out of facilities, moving from levels of care, going to different doctors, it's important to have someone overview all those medications and give you suggestions on, or give the individual suggestions on what types of questions they should ask, what kind of information they should send to the facility or their doctors based on what's happened with their medication, their side effects that are occurring, if they're having trouble taking them, if they're having trouble affording them. So being able to work with that individual to look at everything, to be able to better communicate with the doctors. Because my daughter works in a healthcare system, most of my doctors are in that healthcare system. But even when I go from one doctor to another, they don't always have everything on their, what they call my chart, that's correct. Because if I was put on a short-term course of a steroid for my rheumatoid arthritis, and I'm no longer taking it, it's still going to show up. So they're assuming I'm still taking a steroid. So we need to be able to communicate everything correctly and why we're on it and when it's discontinued, etc. every time we go into a change in a level of care or visit another doctor. Pill organizers and dispensers are very commonly used in older adults. And in fact, I'd require one. That's right, I'm an older adult. But anyway, I happen to use the one in the upper left-hand corner. However, occasionally I drop it or the little compartments open and medication falls out. I'm a pharmacist, so I can recognize what medication's what. What if you're not and you're on multiple medications? So being able to identify what medications in each particular slot should go there requires more additional documentation that's available to the individual should something like that happen. Now, these bottom or these right-sided dispensers are very helpful for people who have memory problems. And you can get these on Amazon easily, and they're under $100. And they do things like set an alarm, or you can't open a compartment until a certain time. I think for someone with memory problems, these are the best to use versus the ones in the left-hand side that can be opened and spilled and things like that. So it's important to pick the right organizer and dispenser in order to make sure that it's safely done. Also, if you look at a prescription bottle, you can tell that it will tell you the exact description of those particular tablets that are in there. And as you know, you may get a different generic product each time. So it's important to understand how to identify what product you're taking by the color, the shape, and the insignia that's stamped on that particular capsule or tablet. So that if you do have that spill, then you can go back to the original prescription bottles and look and see what that drug is actually for. One of the things that I often run into, and I'll be talking with an older adult, and I'll say, well, what do you take for, let's just say blood pressure? Well, I take that white pill. Well, they have like 4 white pills. So do they know which white pill it is? So being able to have a clear sense of the shape, the size, and the insignia somewhere written down is very important. Polypharmacy is a huge problem in the older population, particularly because we do have multiple prescribers prescribing medications. Some don't know what someone else is prescribing, nor do they look at whether or not there's drug interaction or disease interaction or food interaction. So there's concern about the ability to coordinate and adhere to medication doses and frequencies. Someone's ordered several medications. One is twice daily, one is every 8 hours, one is 4 times a day before meals, one is at bedtime. How do we manage all of those? And sometimes we can kind of adjust those in a way that won't compromise the effectiveness, and work with the prescriber to do that. Excessive and additive side effects occur quite often because of polypharmacy. And then interactions between medications. This is a real big thing that we look at in pharmacy. There's a way medication is broken down in the liver that may cause medications to either cause another medication to not be eliminated as quickly, so you get excess medication, or be eliminated more quickly, so you get less efficacy. And then there is interactions between certain medications and foods. A common one is the cholesterol medications and grapefruit juice. Some of them are affected more by grapefruit and grapefruit juice than others. Dairy products with some antibiotics. So we have to be aware of all that. So if you look at statistics, about 30% of all hospitalizations of older adults are due to drug-related problems. So if we can eliminate that, we can eliminate a lot of hospitalizations and reduce healthcare costs.
Excuse me, Dr. Grauer, we have a question in our chat room.
Okay.
Which is from Alice Delois Alexander, and she asked, how do you know a name brand drug from a generic, such as Synthroid?
That's a very good question with that particular drug. Synthroid is one of these drugs. Well, you have to look at depending on what pharmacy you use. Some pharmacists will put, if they're using a generic name, they're going to put the name of the drug that's on there in the bottle on the bottle. Sometimes they will put generic of, but as we look at a prescription bottle, the main ingredient is going to be listed more boldly. Now with Synthroid, there's a lot of controversy about that, because Synthroid is what we call a narrow therapeutic index drug. That means it doesn't take a lot to make changes in the dose of that. So if a generic levothyroxine is dispensed and it's not one of the ones that is closest to Synthroid as far as the amount of drug, and generics have to have a certain amount equivalent to the brand name. So if it's not real close, then it may cause some problems. I particularly recommend with that drug, and that and sometimes warfarin Coumadin, but not so much with that because they're monitoring it more carefully. But Synthroid, I always recommend that you get the brand name, because if an individual has had problems with their thyroid function being volatile, then if they have symptoms, if the dose is changed or not enough is given, and then it's really important that you get that exact dose. So that's a very good question. Generics, most of the time I will say use generics. And if you go to a reputable pharmacy, they're going to use good generics. Synthroid is probably my biggest example of one that I might ask for the brand.
She is on the brand name, she says.
That is good. Stay on that brand name. Others I don't worry about. I really don't. And that it's really uncommon for a pharmacy that's one of your main pharmacies and an independent pharmacy. They're not going to buy drugs that aren't appropriate, that are generics. They're going to buy good generics. So when you think about it, everybody's body is different. So if I take Synthroid or any other brand name drug, my body's going to handle it different than the next person's, to a certain extent. So in most cases, it's not going to make a difference. Synthroid is the exception. Anything else I can add?
we don't have any more questions. I had a couple of things that occurred to me. We've passed them, but my mother, I think, is on a non-necessary drug. She's 86 and she takes hormone medication.
Oh, that's a good one too.
Right. And so she's been on it for so many years that the doctors leave her on it. But I wonder, I mean, it's been a long time.
You know, the use of hormone therapy for someone who's gone through menopause has always been controversial. It can be cardioprotective. It can also increase the risk of female cancers. The question is whether or not it improves quality of life. One of my dear friends is dealing with this very issue now, and I'm 68 and she is as well, now that you know a little bit more about me. And she's been on it for years. If she tries to go off it, she has terrible side effects. She has hot flashes. She doesn't feel well. If I'm 87, the risk of me going off that, I'm not going to do it. Because why suffer the side effects for anyone who's gone through menopause? That's exactly what will happen. Why go through that? Now, if it's an expense, which they are expensive, then certainly if they want to try reducing the dose and seeing if there's any problems, some people might not have problems, then that's an option. But I always look at quality of life, especially when someone gets to be that age. So it just depends on the individual.
It sounds like you agree with her physicians, and so I'm comforted.
Yeah, it's no fun going through hot flashes and night sweats. No fun. So yeah, there's a lot of questions that come up about appropriateness of medication as they get in the 80s and 90s, whether or not it's still effective. Let's just use the example of cholesterol lowering medication. Once someone gets to be that age, the benefit of cholesterol medication has already occurred. So to discontinue it at that point, the likelihood, especially if they're in end-of-life care within the last couple of years of life, that it's really not of any benefit. It's just pill burden and expense, and it can cause muscle cramps. So being able to look at the whole picture of where a person is in their life and whether or not they're getting the benefits has already occurred. Many medications aren't medications that, particularly in chronic disease, aren't medications that work acutely, meaning if you stop them, you're going to get problems. It means that they're preventing future problems. And that's the case with the cholesterol lowering medications.
Here's a good question for you. It's from Talia Lumpkin, and she asked, how do we find an awesome pharmacist such as yourself for our loved ones
your heart.
or patients?
Well, there are geriatric pharmacists that you can look up, board certified geriatric pharmacists that you can look on the board certification. It's called the BPS, or actually it would be the BCGP. There's a locator. Many pharmacists work for companies, and there are some of us that do independent counseling. We do that. My colleague and I, that's what we do is we work with individuals and their families, and we provide that oversight. I can't say that I know of a lot of people that do that, but you can look on the board certification in geriatric pharmacy website. I can provide that information to Sean to see if there's any in your area. We do it virtually. I'm not here to like market myself, but we do that. So yeah, that there are folks out there, and you know, there's a lot of individuals who work with physician groups that you can ask your physician if you can have a consultation with. Now, not all of them are going to be board certified, but there's another certification in ambulatory care pharmacy that some of the general primary care physicians use those individuals, but they're not geriatric. So I can
you said B as in boy, C as in cat, P as in Paul, D.
BCG, Board Certified Geriatric Pharmacist. The American Society of Consultant Pharmacists is where those of us who are board certified in geriatric pharmacy and anyone who does like nursing home consultation, that's our organization. And I'll have to get that information to you, Sean.
Okay.
So yeah, I don't know how many people are like myself that do it specifically in the geriatric, what we would call concierge pharmacists.
Uh-huh.
That makes sense?
Yes, yes.
Okay, anything else?
No other questions here.
Okay, well, let's just move on with, and if more come up, just stop me. So potential consequences of polypharmacy. Well, here are some of them, and these are very, very common. So anytime these occur, we start looking at medication. And how does that impact lives? Well, it's going to decrease the quality of life. Mobility issues are a big one. Disability, many patients may end up in long-term care because they can't figure out why they're decreasing in their ability to care for themselves. And then certainly frailty. You're going to have a presentation later on in the month that specifically talks about how to prevent falls, but medications are a huge component to falls. So the goal is to reduce falls in older adults. I just had my husband's aunt just passed away from effects from a hip fracture. She was an older adult, and she had fractured a hip, and which is very common in the elderly. She was in her early 90s. She passed away as a result of complications of that. So any patient who's taking more than 4 medications have an increased risk of injurious falls. Now, let me just tell you personally, I'm on more than 4 medications. I have some chronic illnesses, and I just fell and fractured my kneecap. So this is very near and dear to my heart. In my particular case, because I'm very cognizant of, you know, some of the reasons medications cause falls, I just was clumsy and happened to fall directly on the cement. But anyway, every medication that you add on top of those 4 will significantly increase the risk of falls. So look at the medications that will increase falls. Medications for all these types of disease states that are very common in older adults, and they affect muscles, cognition. Itching can cause an increased risk of falls, heartburn, infection, all those types of things, and the medications used for those can increase the risk of falls. Confusion. Those very same medications can cause confusion. And it could be that you're saying, either your loved one or yourself, well, you know, I'm getting older, I'm getting more confused. Nobody looks at whether or not it's that medication that's causing that. So those are things that those are the 2 main things that we look at as potentially due to medication problems. Medications are costly. Now, I'm on Medicare with Part D, and I'll just tell you, I was on a medication for my rheumatoid arthritis, and before I went on Medicare, I could do the assistance program. It was $100 for a 3-month supply. It happened to be Enbrel. And I went on Medicare Part D, and if I were to get that medication today, it would cost me $2,200 a month. I fortunately am aware of alternatives, so I asked my doctor for an alternative, and I'm on that. Does it work as well? No, but I can take my my naproxen, and it helps with my pain. Something's wrong there. But
I was thinking the same thing, and we've talked about the cost of medications in a prior CEU, but I mean, I thought Medicare had just realized the ability to negotiate. Is that not in process?
that is in process. What does that mean, though? I can tell you drug companies have incredible lobbying ability. So I'm standing back, waiting to see what it means with my particular medication. But you're right, Sean, that has just occurred. And I was going to mention that.
Let me, at this point, I'm sorry to interrupt, but our evaluation is password protected. And our password, it's 1250 or so, is Profero, which is spelled with a capital P as in Paul, R-O, F as in Frank, E as in Edward, R-O, Profero with a capital P. And that is the name that you see at the bottom of your screen. It is Dr. Grauer's consulting arm, if you ever wish to use her. That's our password. Thanks so much.
Okay, well, I will kind of buzz through these next few slides. So what they're advertising on TV are going to be the most costly drugs. And they give you every reason to use them. And I can tell you a lot of physicians will be marketed those drugs by the drug companies, and they will be prescribing them. Now, your insurance company may give you very high costs on those because of their tiered system. So you want to be aware of that. And we look for other alternatives. Now, oftentimes your insurance company will give you alternatives to what's prescribed. But there are certain things, for example, if it's recently come out in studies that certain drugs are more effective. For example, I'll tell you Farxiga, which is a drug that is for diabetes, has been approved for heart failure. Not for diabetes, but for heart failure. And cardiologists are prescribing that. And it's a very expensive drug. So, it also has to do with what studies have been done. And the people that pay for studies are the drug companies. So, it's kind of skewed. So you need someone who's knowledgeable in alternatives to be able to look at, well, yeah, it just came out in the drug study, but let's reevaluate the drug study and see if it really, really is important. So, it really takes someone who's knowledgeable. Drug stacking occurs a lot of times. I told you of confusion and dizziness and things like that. It may be that you get prescribed a medication because of the side effects of another medication, where you could have changed that other medication and not had an additional medication prescribed that would have saved polypharmacy and saved cost and reduced side effects. The other thing is there's a lot of consumer plans out there right now. You have to be careful with CE on advertising certain drug plans, but like the RX plans that you're seeing, that you take the card in, and I'll tell you, I use those. I think they're very, very helpful. Medication lists are absolutely essential. It really helps identify all the medications, prescribed, over-the-counter, supplement, and herbal that you should take to your provider every time you go, and needs to be updated on a regular every time there's a change. And you need to be able to take it when you're going from one care site to another, one doctor to another. So as individuals go from place to place, each provider has their own list. So each pharmacy, how many people go to just one pharmacy? Very few. Mail order. If you're using a product like, don't say it, tell that I said this, like GoodRx, it may say the best prices at this pharmacy for this drug, but the best prices for that pharmacy. And what happens is, if you don't have a list, a lot of mistakes can occur because each provider, each pharmacy has their own list. So we help maintain those lists. And this is one of the forms that we use a lot. And it gives the medicine other names, the question about Synthroid versus levothyroxine, which you'd know that here. Directions, the use, who prescribed it, when it started, and any information that we feel is important for the individual to know. So let's look very quickly at Martha. Martha is a 78-year-old, family lives out of town. She has multiple diseases. She has a lot of complaints. This is her medication list. So we have the use there. Now, I would probably, on a patient who doesn't know a lot of these terms, like diabetes, I might put for blood sugar, osteoporosis for bones, dementia for memory. I might change the verbiage on this, but why it's being used is very important. The prescriber, see, there's more than one prescriber here, and that's important to know. The start date. Some of these have started, look back 1995 on the Paxil or paroxetine, and then important information. Now, if we went back to all her complaints, look at the drugs that may impact her complaints. If we could relook at those and adjust those, many of those complaints very well could go away. So it takes looking at medication from a very high level, looking at the who's prescribing it, why it's being prescribed, the patient's age, the patient's location, do they have a caregiver that can help with the medication? How can we adjust that medication so that it's easy enough to remember? Is it still appropriate? All those things go into looking at medications from my perspective as a older adult pharmacist. So why have a dedicated one? You go to a pharmacy and they're very busy. They're not accessible. Older pharmacists can work with the individual to coordinate all their medication therapies. We have to do, when we're working with someone outside our service area, we do virtual visits and as needed consultation. When the individual gives permission, we talk to the providers, the caregivers, and the loved ones. So we educate, we help them take their medications to avoid medication misadventures, and we also guide them on proper disposal. Because remember, if particular medications are available in the home, they are targets for people who want to abuse them. And then communication is the key. So anyway, that's the importance of medication in older adults and the oversight that we need to provide to them. So I think I'm ending right on time.
You are. It was perfect. I expected no less than perfection from you, as I've seen you lecture on so many occasions at the National Hospice and Palliative Care Organization Conference in Washington and Ohio and West Virginia and Pennsylvania and many other states. And always a pleasure and always learn something. I know I did, and I feel like our attendees did as well. I thank you so much for doing this again. It is truly a blessing and an honor. And I'll share with you our results from our password protected evaluation, which folks are already going to. And then I would certainly appreciate that any of you that would like to present for us are welcome to do so. And anyone that has any any advice on how we can do a better job or bring in greater or more great speakers, rather, like Dr. Grauer. You're getting a lot of thank yous from Artidra Siggers, Amy Jo Mann, Jernisha Smith. So I'm so pleased, Phyllis, Dr. Grauer, and I appreciate you being with us today. And as we're a little past the hour, I'll go ahead and end it. If you'd like to say anything else, please do so.
I'd just like to thank all of you for joining us today. You know, this is something I'm very passionate about, and I appreciate you being here.
Oh, thank you so much. Y'all have a great day.